Welcome to this explainer. Today, we're diving deep into the mechanics of asthma and breaking down the brand new GINA 2025 treatment protocols. We're going to distill exactly what happens inside the lungs, how it's diagnosed, and how modern medicine is fighting back.
All right, let's start right at the foundational definition. Asthma really rests on three pillars: chronic airway inflammation, bronchial hyperresponsiveness, and crucially, variable obstruction. Unlike other chronic respiratory diseases where the airway narrowing is fixed and constant, asthma is uniquely dynamic. The airways can severely narrow in response to a trigger and then fully open back up, either spontaneously or with medication. That variability, that is the absolute hallmark of the disease. Here is our agenda for today. We're going to cover 1. Etiology and pathophysiology, 2. Clinical features, 3. Diagnostic investigations, 4. The GINA 2025 treatment protocols, and 5. Acute exacerbations.
So, Section 1, Etiology and Pathophysiology, specifically looking at the IgE-mediated cascade.
It's honestly fascinating to see how the strongest risk factor here, IgE-mediated atopy, physically alters the lungs over time. When a patient with a genetic family history is exposed to triggers, things like pollen, dust mites, cold air, exercise, or even viral infections, this massive allergic cascade begins. And this isn't just a temporary spasm, right? The actual pathology involves eosinophilic infiltration. Basically, these immune cells flood the airway tissues, leading to mucus hypersecretion that literally plugs up the breathing tubes. Eventually, you get smooth muscle hypertrophy. The muscles wrapping around the airways actually thicken and get stronger, which just makes future spasms even more severe.
Now, this intersection of triggers brings us to a really interesting clinical quirk. It's a high-yield exam point, too. Samter's triad. This links asthma, nasal polyps, and a sensitivity to NSAIDs, like your standard ibuprofen or aspirin. If a patient with this triad takes an NSAID and then, say, steps out into cold air, it can trigger a rapid, incredibly severe asthmatic cascade. It's a perfect example of how environmental triggers and pharmacology can dangerously intersect.
Moving right along to Section 2, Clinical Features and Signs, the episodic presentation.
Because of that variable obstruction we just talked about, the symptoms you'll observe are highly episodic. The patient is going to complain of a whistling wheeze, a really tight feeling in their chest, breathlessness, and a cough. And when you actually examine them, the physical signs tell this story of trapped air. You'll notice hyperinflation of the chest, and when you listen with your stethoscope, you're going to hear an expiratory wheeze along with a distinctly prolonged expiratory phase. Essentially, they can get the air in just fine, but struggling against those inflamed, narrowed tubes to get the air back out, that takes way longer.
But here's a crucial detail. Asthma isn't static throughout the day. Patients frequently experience what we call a diurnal variation. A patient might look and feel relatively fine during a 2 p.m. appointment, but their symptoms, especially that tight, breathless coughing, are significantly worse at night and in the early hours of the morning. Tracking this day-to-night variation is a massive clue for your diagnosis.
Okay, we need to pause here and shift to a very serious note. While wheezing is the classic sign of asthma, an absence of wheezing during an attack is a massive red flag. We call this the silent chest. It is a truly ominous sign because it means the airways are so incredibly tight and inflamed that air isn't moving at all. There isn't even enough airflow to generate a wheeze. If you see a silent chest alongside an inability to speak, a racing heart rate, rapid breathing, or a peak expiratory flow of less than 50% of their predicted baseline, you are looking at a severe, life-threatening emergency.
That brings us to Section 3, Diagnostic Investigations, establishing the baseline.
When we do diagnostic spirometry, less than 0.7 is the magic number. When you have a patient forcefully blow into a spirometer, you're looking at the ratio of forced expiratory volume in 1 second to their total forced vital capacity. An FEV1 to FVC ratio of less than 0.7 definitively confirms obstructive lung disease. It proves that something is blocking the air from easily exiting the lungs.
But wait, COPD is also an obstructive disease, right? So how do we prove it's asthma? Well, to prove that the obstruction is variable and reversible, which is what actually defines asthma, we need to administer a short-acting beta agonist, a SABA, and test them again. We are looking for a post-SABA improvement of greater than 12% in their FEV1, alongside an absolute volume increase of at least 200 milliliters. If you see that 12% jump, you've just proven reversibility. You've proven asthma.
We also have another fantastic tool nowadays, FeNO, or fractional exhaled nitric oxide. A level of 40 parts per billion or higher is a highly specific indicator of underlying eosinophilic inflammation. It essentially allows you to measure the amount of active, allergic-type inflammation happening right there in the airway tissues.
To round out the diagnostic picture, we can send the patient home with a peak expiratory flow diary to track that day and night difference we mentioned earlier. We want to see a diurnal variability of over 20%. On top of that, we can run allergy tests, like skin prick tests, or check serum IgE levels to pinpoint their specific triggers. And finally, you should always order a chest x-ray. Not to diagnose asthma, mind you, but specifically to rule out other sneaky pathologies that might be mimicking it, like a hidden infection or a structural issue.
Let's move to Section 4, GINA 2025 Treatment, the Stepwise Protocol. The entire philosophy of the Global Initiative for Asthma, or the GINA guidelines, revolves around a continuous cycle of assessment and stepwise adjustment. You escalate therapy when symptoms are uncontrolled, and you carefully de-escalate when they're stable. And the core rule of modern asthma management is balancing a controller medication, which reduces that underlying inflammation, with a reliever medication for immediate symptom relief.
Let's walk through the early stages. The big shift in GINA 2025 is a heavy reliance on MART, maintenance and reliever therapy. Historically, patients used a daily inhaled corticosteroid and a totally separate rescue inhaler. But GINA 2025 highly prefers a single combination inhaler, a low-dose ICS mixed with formoterol, which is a fast-acting, long-lasting beta agonist. In steps 1 and 2, the single inhaler is both their daily controller and their instant reliever. By step 3, they move to a dedicated daily ICS LABA maintenance dose while still keeping a reliever strategy in place.
Now, if things are severe and uncontrolled, we step up to step 4 by adding another bronchodilator, like a long-acting muscarinic antagonist, or LAMA, such as tiotropium. But step 5? That is where the cutting edge of medicine really shines, targeted biologic therapies. We can use omalizumab to neutralize IgE, or mepolizumab to block interleukin-5, which is the exact pathway that produces those troublesome eosinophils.
Finally, Section 5, Acute Exacerbation Management.
When a patient crashes in the emergency department, struggling to breathe, your immediate reflex has to be bronchodilation and oxygenation. We deliver 4 to 10 puffs of ASABA through a spacer to make sure it hits the deep airways. If they aren't turning the corner fast, if that severe wheeze persists or their oxygen saturations just won't climb, you have to aggressively attack the inflammation by initiating systemic steroids, typically 40 to 50 milligrams of prednisolone, STAT.
So we've covered the structural damage of the airway, the exact diagnostic thresholds to prove reversibility, and the precise escalation of the GINA 2025 protocols. But considering how powerfully we can now target those specific IgE and IL-5 immune pathways in step 5, it leaves us with an incredibly exciting question about the ultimate future of respiratory medicine. As these biologics become more advanced, are we moving toward a future where severe asthma is actually cured at the cellular level rather than just managed with inhalers? It is a fascinating space to watch. Thanks for joining me on this explainer, and keep that crucial question in mind as you explore the evolving science of airway disease.